what I want to do is to kind of canter through some of the issues around strategies for mitigating risk and think about what risk means in this emerging NHS with new commissioning entities being created. So risk, as it's been mentioned, it's part of this debate about centralisation, about localisation. It's about issues of autonomy and control. A risk-averse system might be a very centralised one, but maybe it hasn't got that local discretion, that local innovation, that local energy that we're looking for in commissioners. The bill talks about a risk pool, and we really need to move on thinking about how we handle both underspends and overspends at the end of a year. Particularly important at the moment as we think about CCGs, potentially smaller commissioning entities, and I'll give some examples of why that's important, more complex markets, a more complex range of actors involved in the health economy, and a renewed emphasis on organisational autonomy. I think the issues for me are though about how we design risk systems that reinforce the right incentives for efficient care, and we don't rely on a process of just bailing out failures for when people are perhaps inefficient or overspending. So the reasons for why our budget at the end of the year might differ kind of classically fit into 4 broad categories. Could be acts of God, random events, bad luck. It could be problems in the way that budgets or allocations are set. Number 3 is particularly important as well. Is it something about the practice of local care that's efficient or inefficient? Then the 4th one is a variant of that, and this is really quite important in thinking about the regional imbalances in the way that money is spent around the NHS. And in terms of scale, that's still really large. Very quickly, here's 2 examples. This is actually a practice level example. Month by month, this is their use of acute hospital care. The blue line in the middle represents a notional allocation using a standardised model. The red line indicates their observed costs, and what you can see is it goes completely crazy somewhere in the middle. Presumably some random event, something that the organisation itself had very little control over. That situation is different from this practice. This practice, the little red line shows the observed costs wibbling about the expected in a really quite controlled way. But in this one, it's throughout this 3 years of the analysis, it's consistently higher than it would be expected, above the notional allocation. How have we handled these things in the past? Well, we've had a range of mechanisms. We have arrangements for specialist services, either national ones or sometimes local PCTs. We have some approaches towards block contracting, which effectively put risk back onto the providers. We've heard about the SHAs and their top slicing. And at the moment, there is a kind of system, or there has been historically a system of ex post, after the event subsidies, basically to even out those end of years problems, to help organisations through, particularly where they've had a deficit. There's 3 broad approaches. The risk-bearing ones, which is about spreading the costs either for a larger risk pool, a larger organisation, or over time. There's the risk sharing, which means working across organisations to pool some of their resources. And then there's the processes of transferring financial risk, the carve-outs and the examples of specialist commissioning are one example of those. Specialist commissioning is one of those areas where there's quite a lot of detail to understand about whether or not it's appropriate for local commissioning entities to be engaged in the commissioning. There's some uncertainty about exactly what constitutes specialist commissioning at a national level. This is an example of some work that we did using a definition that we had, and we reckon about 14% of expenditure currently fitted in one definition of national or regional specialist commissioning. And then the question is it appropriate for that to be handled by the CCGs locally, or should it be handled as it is at the moment with national mechanisms? And should there be the same mechanism across the whole country? You can also ask the same question about critical care, which happens for fewer people but can be extremely high cost. The next one is about size. We all kind of know this, that the larger the organisation, the more stable the budget. And this illustration here is based on random pseudo-CCGs. What we basically did was randomly allocated practices within England to a CCG of varying sizes. So these are artificially created. And then what we looked at was their observed costs and their expected costs from a national model that might be used in, say, budgeting or allocation. And the column that says within 1% indicates the number of CCG-like organisms that fell where the observed cost was within 1% of the expected costs. And you can see as the organisational size increases from approximately 100,000, where it's only 39%, up to 500,000, where it's 73%, the larger the organisation, the much closer to that expected cost. So the random effects are much smaller. What happens if we extend the budgeting time period? Once again, we've been able to do some artificial experiments looking at historic costs. And this graph actually shows what happens when you change the allocation period from 1 month up to 48 months. And once again, the metric is this is based on GP practices that fall within 5% or 10% of expected. In the middle, you've got the 12-month, the typical annual cycle, where 68% of the practices will have fallen within 10% of the expected. I think we were surprised to see that actually if you increase that to 24 months, a 2-year period, it doesn't actually go up by that much. And then the most commonly cited strategy, I couldn't think of a song about truncation, unsurprisingly, is a thing called truncation with stop-loss insurance. For some patients where costs exceed a given threshold, perhaps another entity might pick up those excess costs. Just to give you an idea about how these numbers fall out, this little table shows you at different levels of truncation what proportion of hospital expenditure, again secondary care expenditure, would be excluded. And so typically people talk about truncation in terms of cost per person per year of 15,000 or 20,000 of constituting excessively high costs per patient. At 15,000, you're actually picking up 9% of the total hospital spend. At 20,000, it's falling down to 5%. So significant amounts of money. So we looked at applying different truncation levels as well. Once again, the graph on the right. And it shows that actually increasing the level of truncation once you've excluded specialised services doesn't make a huge amount of difference in terms of the variance from expected budgets. Once you get above a certain level of about 15,000, those graphs actually appear to be fairly flat. These types of analyses show us that the importance of population size, the importance of the list size for the CCGs, and how unstable some of the budgets for very small organisations can be. We were surprised that the break-even period didn't make that much difference and that truncation was actually quite limited. Important to remember those underlying regional differences as well and the range of options that can be applied on service carve-outs and the exclusions of specialist services.